this last Wednesday, of June. Once again, Smilow Cancer Hospital has been putting on this series, this Smilow Shares series for the month of June, where we celebrate cancer survivorship. And so we're looking forward to having a great conversation tonight with all of you. We've got a great program. We're really gonna wrap up the month really strong here. So I'm gonna get right to it. Actually, before I do, I'll just say that if you have questions, you can put them in the chat. We're gonna try to go one right after another, just so we've got a good flow of a program, and then we'll try to answer all the questions that are in the chat, or if anybody else wants to unmute themselves at the end. Okay, so we're gonna go from one speaker to the next. We're not ignoring your questions. You can definitely put them in the chat, and we'll get to them collectively at the end. So with that, tonight what we're going to be talking about are some of the hidden concerns with long-term survivorship, and what we can do to kind of address those. So I'm going to start by introducing my friend and colleague, Kristen Madrid, who is the social worker for Smilow Cancer Hospital, the breast center, and surgical oncology, as well as she is the social worker for the survivorship clinic, which we'll give you more information about that at the end. Additionally, Kristen is facilitating the early onset cancer support group for ages 18 to 49 who are in active treatment and who are cancer survivors. And I can tell you that she's also a chocolate aficionado and a fan of stroopwafels. Moving on, Johanna is a PA in the Women's Oncology program, and she's the coordinator of the Sexuality, Intimacy, and Menopause program, which is abbreviated SIMS, program for cancer survivors. This is a great program. It's been around for a bunch of years, and it really helps to address a lot of these taboo things that patients feel kind of embarrassed to talk about. So it's a great clinic that we have to offer. And she also works part-time in primary care. You might see a cameo from her very cute 2-year-old. Well, that's how we roll with virtual presentations in 2024. And then Gabriel Cartagena is new to Smilow Shares. I think this is your first presentation, Gabe. So thanks for being here. Gabe's a licensed clinical psychologist and the leader of the Yale Psycho-Oncology program at Smilow Cancer Hospital. He specializes in health psychology and is trained in providing evidence-based psychotherapy to help treat mental health conditions such as depression, anxiety, insomnia, and PTSD for people living with cancer in both English and Spanish. So he's bilingual and be able to help to break down some of those barriers right there. Sometimes our patients have a language barrier, so breaking that down right away, which is great. And I guess I should introduce myself. I'm Scott Capozza. I'm a physical therapist at Smilow Cancer Hospital. I am also the physical therapist for the Smilow Survivorship Clinic. I'm the last original member of that program. If you can believe it, our cancer survivorship clinic started way back in 2006. And I always have to tell people that I'm not lymphedema certified, but I am board certified in oncology physical therapy, and I am the only physical therapist throughout the Smilow network that has that board certification. So while I may not be lymphedema certified, I am certified to treat everybody else who walks in the door. So with that, Kristen, I'm going to turn it over to you and have you kick us off.
Sure. Thank you, Scott, for the introduction. I'm just going to start sharing my screen here. Okay. So welcome, everybody. For my portion of today's webinar, I'm going to be discussing distress and post-traumatic growth. So specifically how that long-term distress can relate to cancer survivorship. So the overall impact of cancer is vast. It can be incredibly distressing, and that stress can occur long-term, regardless of what phase you're in, whether it be active, extended, or long-term survivorship. The impact of cancer can also have a pretty detrimental impact in various different ways. Listed here are just a few of many ways that cancer can pose an impact or lead to significant distress in an individual diagnosed with cancer. Oftentimes when one completes treatment for cancer, they don't necessarily feel like celebrating per se. They actually don't really feel ready to move forward. That sense of support and intensive support you get from your teams naturally tends to fade. And a lot of people ask, what do I do now? Because these are the numerous ways that I have been impacted by this diagnosis. The transition period post-treatment is actually when survivors experience the most distress. So one may experience a spiritual impact, such as concerns with meaning and purpose, an emotional impact such as depression, anxiety, fear of a cancer recurrence is a big one. Oftentimes people describe their cancer journey, if you will, as a tidal wave of emotions that builds up and keeps building up, and you don't start to feel those effects until post-treatment when it all comes crashing down. In addition to that too, there's of course the long-term physical impact that these treatments can have on an individual, and also, much to what my colleagues here are going to discuss, the impact this can hold sexually, socially, and definitely financially, because this can be a very financially toxic process. So how do I know if I'm experiencing distress? There are different indicators, just to name a few per se. Excessive fatigue or exhaustion, feelings of hopelessness, difficulty controlling your emotions, changes in appetite or sleep, feeling increasingly withdrawn, a notable increase in anxiety or worry, just to name a few. And distress can also present itself physically too. You may notice that you're prone to more headaches, stomach pains, shakiness, however that may present. There may not be a clear-cut reason for it. It can actually be not necessarily a physical issue, but rather an emotional or distress issue. So how to cope with cancer-related distress? These are just a few of so many different ways that one can cope. There's various different skills or interventions to utilize, and the ones in bold are ones that I've gotten feedback from many patients about that they found to be particularly helpful. We have quite a few different support groups here that many find helpful because they get that sense of understanding from fellow individuals who have gone through similar treatment processes. Counseling has been helpful, such as our psycho-oncology program has been incredibly helpful for many. Exercise is very helpful. Sorry to be repetitious, but very good for improving or enhancing our emotional and mental well-being. Tapping into your spiritual or religious belief systems, our general support systems too. Process through with them what you've gone through and how that's impacted you, as well as engaging with those activities that you find particularly helpful for you in the realm of self-care or leisure. And of course, the other skills listed here too have been known to be pretty helpful. So what is post-traumatic growth? There's the textbook definition there on the screen that you can absolutely take a brief moment to read. But essentially, post-traumatic growth is where someone who's been affected by a traumatic event such as cancer finds a way to take new meaning from this experience. And with that meaning, they take away a sense of how to live their life differently than they lived it prior to that traumatic event, so prior to cancer. Different areas for growth that can come from PTG, for short, could be enhanced sense of personal strength, increased self-awareness. It could be an appreciation for life, definitely is a very common area for growth for many. Finding new opportunities, new priorities, spiritual change. There's so many different areas for growth that can occur from a traumatic event. And it's a way of, much to what this definition states, a way to unintentionally yield changes in understanding oneself despite that adverse event. So, many may ask, how necessarily could I grow from a traumatic event such as cancer? There's no clear-cut way per se. Every individual's experience is different. But if we were to define it in some sense, there could be avenues that you can take. Reflection is a big one. Reflecting on your experiences and the emotions that resulted from this event or this diagnosis. While being mindful, of course, that trauma impacts us all differently. Don't suppress your emotions in pursuit of optimism, but rather, express instead of suppress. Our negative emotions can increase our chances, or rather, expression of our negative emotions, I should say, can increase your chances of benefiting from post-traumatic growth. And so talk to and write through, if that's your preferred mode of expression, all of the impact that you've faced from this diagnosis, and work through it. And whether that be personally with your support system or with a professional, it's definitely important to really work through how this impacted you in all different areas or realms. And pull upon your sense of community and your support system. Again, I can't emphasize that enough. And I definitely acknowledge not many people have a ample support system. So seeking ways to foster a sense of community and seeking support from those that understand your experience. And even if they may not personally understand, they can offer some level of understanding or acknowledgement of what you have gone through. And different outcomes we've seen of post-traumatic growth have been, lying in the understanding that post-traumatic growth or traumatic or adverse events, I should say, have the potential to generate positive benefit. So with that being said, when we achieve that positive benefit, so to speak, you might notice positive changes in self-perception, positive changes in interpersonal relationships, again, that increased self-awareness, increased self-confidence, discovering new possibilities. And to give an example of what post-traumatic growth may look like, I'm sure, Scott can attest to this too. We've had patients who post-treatment, they take their time to really adjust and process through that diagnosis and how it impacted them. And they find that maybe they, end up changing religions, changing careers. They find that, although this isn't a positive experience by any means, again, that adversity can then yield changes in understanding themselves, others, in the world around them. So there's different changes that cancer can cause, but not necessarily all negative. So different resources that myself and my colleagues often reference for cancer survivors that are particularly helpful are listed here. Just to kind of briefly touch upon what each one offers. Cancer Survivors Network, which is a resource portal operated through American Cancer Society, is a peer support community that's diagnosis-based. So that's where you'll find individuals who can really, truly understand and acknowledge what you've been through and the specific kind of side effects or treatments that you've been through. We have our Yale Cancer Center Survivorship Clinic. I'm not biased, but I think it's a really great asset and resource to utilize. You'll be able to meet with a multidisciplinary team, social worker, a physical therapist, a registered dietitian, and our EPRN. And you'll really get a overarching all-around approach to survivorship care and recommendations in relation to a lot of those questions that you may have regarding what do I do now. For financial toxicity experienced by a diagnosis, Triage Cancer is definitely one of the #1 resources that we recommend. They have a lot of really great webinars, information, and resources to alleviate that financial toxicity. We often, tap into our psycho-oncology program. We tap into, local counselors or therapists in the area. But if you want a really tailored referral for someone who is local to your area, accepts your type of insurance, we can utilize Psychology Today. And up until a couple weeks ago, they never had a tab to filter out therapists that specialize in cancer, but they recently added that in. So that's something you can definitely do if you want a professional who specializes in this particular area. There's the National Coalition for Cancer Survivorship, and cancer support community, which offer a really vast, great deal of resources in all different areas. And then there's the diagnosis-based support. So, your clinic will likely have a social worker. And the reason I recommend consulting with them is because there's a lot of different resources out there that are specific to your diagnosis. And it's impossible to list them all here because there's so many different types of cancer. So if you connect with your clinic's social worker or the social worker that's partnered with your oncologist, I guarantee you there's going to be a pretty vast list of things to then help support you as you adjust post-treatment, as you work to process through this experience that are specific again to the unique diagnosis that you were given. And that's all for my portion. So I'm gonna pass it over to Johanna.
Okay. I'll take it over. And Kristen, thank you so much for sharing that. I will never forget when I learned that term post-traumatic growth from Dr. Samft at one of the survivorship webinars. And I took a lot from that term because I think it's such a special and meaningful term, post-traumatic growth. So let me take over here. And I wanted to welcome the survivors and thrivers that are here, as well as any partners that may be here. If there are any, you're welcome as well. And in our Sims clinic, partners are always welcome. So I want to share this with you if I can figure out how to do it. So here we go. All right. So it sounds a little bit strange, but I am talking about 3 different topics that are kind of interrelated, and I'll explain to you why. And thank you, Scott, for the great introduction. So I'm Johanna, I'm one of the PAs, and I am housed in gynecologic oncology, which is a clinic over by the boutique and over by integrative medicine on North Pavilion 1 in Smilow. And we're part of gynecologic oncology, but we see patients from all different cancer clinics. And right now we have focus on patients who are born as female. We do have some patients who kind of go to our sister program or brother program that used to be run by a urologist, Dr. Honig, and he still sees a lot of our male cancer patients, but Dr. Cartagena is kind enough to talk about some of the male sexual health challenges today. So I'm going to talk to you about female sexual health and also intimacy, which is a little bit different, but very related, and bone health, which may not seem related, but it is in the female cancer population because early menopause often happens in cancer survivors, and early menopause can cause bone loss, leading to osteopenia and osteoporosis. So that's why it's all tied together here. So I'm going to start with why it matters. I didn't make a very pretty slide, but it's a very factual slide here. So sexual health matters because even people who have cancer and do not have a sexual partner can be sexual beings. Sexuality is part of our identity. And in some patients, it's a big part of their identity. And in some patients, it's not a big part of their identity, but it's whatever it means to you, sexual health is important. And I want you to know that it's important, even if your clinicians and providers are not always asking, because either there isn't enough time in a short visit, or there's discomfort on the provider level in asking, or it just doesn't come up in conversation. But I want you to know that sexual health matters. In the National Cancer Survivorship Guidelines, it is a guideline for us that we should ask about sexual health because it's part of overall health and it's part of well-being and quality of life. So if we're not asking, and you want to talk about it, please make sure to bring it up with your providers, whether it be with your social worker, your nurses, your oncology team, the APRNs and PAs, or the oncologists that you're seeing. If it's important to you and you're having trouble, ask for help because we can help you. Sexual health can be impacted by cancer for multiple reasons. And I always tell patients when they come to the clinic, well, there's the physical part of your cancer journey, whether it's chemo side effects, surgical scars, pain, sleep problems, all these things can be physical. There in people who have chemo, there are often hormonal changes. or in some of our women who've had to have certain surgeries, there are hormonal changes as well. This is what I refer to as menopause. And then there are emotional changes. So the emotional changes are significant that Kristen alluded to, but also just change in partnership, change in roles in a relationship, a lot of that fear, anxiety, change in your priorities, shifting priorities in your life. So these can all impact sexual health in different ways. So how do we address sexual health? Well, number one, like I said, please don't hesitate to bring it up. If it's a concern, bring it up with anybody who you feel comfortable with, whether it's at your visit, whether it's on a MyChart message, just feel free to ask. And if your providers can't address it, they can get you to me or get you to Dr. Cartagena or somebody who can help you with some cancer-related sexual health side effects. We can help you manage treatment side effects. Your team is really good. Our oncology teams are excellent at managing fatigue, nausea, some of those chemo side effects that used to be really terrible. Now we're better at managing those, I hope. And I think we really are. Pain, neuropathy can be a big one, strength and loss of strength, and sometimes related to nutrition. And just making sure you have good nutrition and your treatment side effects are managed so that you feel like you have the energy to be sexual. Because if you don't have any energy, if we're exhausted and don't feel well, it certainly will impact our sexual health. When you can, make sure to get plenty of sleep, get plenty of nutrition, and make sure to stay hydrated. So, another side effect of treatment can be anemia, which can cause a lot of fatigue too. So make sure your blood counts are getting monitored, your side effects are being monitored, and that you're maximizing kind of your general wellness. And I didn't put exercise on there, but exercise, of course, helps when we have time and energy to do so. But really try to rest and take care of your body so that you can have energy to be sexual if you so choose. From our perspective in our clinic, we do a lot of medication management. And so just to kind of explain the SIMS program, we were developed in the early 2000s, just like the survivorship program, and we've been around for a long time. Many cancer centers across the country have sexual health programs and intimacy programs, but they don't all have prescribers. A lot of them are run by people who are excellent at talking about sexuality, guiding people on how to have communication with a sexual partner, but may not have the capability to prescribe hormones, medications. There are non-hormonal treatments for a lot of sexual side effects. We do have prescriptions, and as providers in the clinic, we can prescribe things for sexual desire, what we call low libido. For our patients that are female, we have vaginal dryness and pain, and we can manage that with different medications, either over the counter or prescriptions. And also for menopause symptoms, and for some of our guys who also have some hormonal treatment, especially in prostate cancer. We have hot flashes and night sweats, which we can manage with prescription medications. Some of them are hormones, and for people who can't have hormones, we have other prescriptions that can be used for some of these symptoms. And so if we manage some of the symptoms, hopefully sexual health will be positively impacted. So switching from sexual health to intimacy. Intimacy is a little bit different, but similar in that intimacy can be a lot of things. It can look very different, and it's kind of a bucket term for our relationships. So who are we intimate with? And what does intimacy look like? And it may be different than pre-cancer diagnosis. So you may have different intimate moments, maybe cuddling, hand holding, going on date nights. But it may not be sexual activity. It may not be intercourse per se, but there still is this importance of intimacy, especially in a cancer diagnosis, and especially for our patients who are at end of life. Intimacy can be really, really important, as one of the priorities near the end of life is just having a moment with a special loved one. And we absolutely certainly need our support system during and after our cancer treatment, and the whole journey. And I will say, I give credit to the partners out there who might be on this Zoom. Partners are certainly part of the journey, and partners go through maybe not the physical aspects of cancer, but they certainly go through their own emotional impact of being a partner with somebody who's going through cancer. So being that, before perhaps it was a partner relationship, and now it's a little bit more of a patient and caregiver relationship, or both patients are really suffering with some emotional stuff from the cancer diagnosis. So we need each other to get through that. We need each other as partners and support systems. Um, and there's this desire to feel close and connected. And again, this shifting priorities of, you know, now that I have cancer, maybe my job or something else is not as important to me as spending time with my loved ones and spending time with myself doing the things that I enjoy. And so intimacy really becomes an important aspect of cancer care. Um, there certainly may be some stigma about it, talking about sex, talking about being intimate. Again, bringing it up may be challenging, it may be embarrassing. There are people who come to our clinic and say, well, geez, I've never really talked about sex or intimacy before with any of my doctors, even at my regular physicals, but now it's becoming a little bit more problematic. So it's more important, but it's okay to talk about it. And it's okay that your sexual life and your intimate life is different than it used to be. And it's something that we can try to help with. And I can't possibly always make it perfect again or make it as it was, but we can try to make it better for you. And then there's certainly just the anxiety and fears, and hopefully some of that post-traumatic growth as well, and the positive emotions that come with cancer survivorship. But we can help you work through those and help you. The great thing about the Sims clinic at Smilow is that from day one, the doctors who I work with that are excellent and that who developed the Sims clinic, they felt that we needed our psychology team as part of it. So we always have our psychology folks available to us, because we know that sexual health and intimacy are certainly not just physical, they're also emotional topics. So again, same thing, bring it up with your team, ask for support, ask for a referral, work with your partner if you have one to talk about it. We can also help to kind of navigate that conversation and explain, how intimacy and sexuality may be affected by cancer. We have a lot of patients who say, I feel guilty that I don't have sex with my partner. I said, well, you're going through cancer. The last thing you should feel is guilty. So we try to work with you on some of those emotions and the communication with the partners. Think about other forms of intimacy if it's something that you want to consider. Again, the hand-holding, the cuddling, the dates, the outings, taking a walk together, talking about life, massage and touch, things like taking a shower or bath, things that may not necessarily involve intercourse because that may be more challenging for you physically and hormonally, but things that you can do other than sexual activity. And then we shift gears a little bit. So bone health. And I wanted to really bring this up in survivorship in Smilow Shares this year, because I think bone health is really important for cancer survivors, especially women who have early menopause. So people who go through menopause, whether it's from chemotherapy, if they have to have a hysterectomy and have the ovaries removed, radiation to the pelvis, all these things can put women into menopause. And the bones like estrogen. And so after menopause, when we don't have estrogen floating around in our bloodstream, the bones can get what we call porous, where you can see that little image on the bottom. And this is not something that you feel. You don't feel achy. You think about like arthritis. This is not arthritis. This is actually loss of what we call bone density. So your bones can get a little bit weak. And Scott may see this in his PT clinic a lot. And so the concern with osteoporosis is that you can break bones. You can have even if you have a minor slip and fall, you're more prone to breaking a hip, breaking a wrist, breaking an ankle. Some of the other things you can have, like a spinal fracture can happen from osteoporosis. So these are things that can really impact people as far as their mobility and quality of life. So it can happen with early menopause. So I want to kind of just put it out there for you. If you have questions, talk to your providers. Exercise sometimes is hard during cancer treatment. And even after cancer treatment, there's some good evidence to show that people have a lot of fatigue after cancer survivorship. And so they're too tired to exercise regularly. And so that can also impact bone health. So we have to try to prevent it as best we can. And how do we do that? Well, number one, ask your medical team. You may need a bone density exam to check your bone density. So ask about that. And then the two vitamins, minerals that are helpful for bone health are calcium and vitamin D. And vitamin D, we like to think we get in the sun, but in the US, we don't get a lot of sunlight. We're not really outside much. And when we are, we're hopefully wearing sunscreen, which is a good thing for your skin. But we're probably not getting enough vitamin D from sunlight. So we want to take some calcium and vitamin D supplements. And I like to remember, I tell people, think about 1,000 a day because it's pretty much easy to remember. About 1,000 milligrams of calcium a day and about 1,000 units of vitamin D a day. And that can be from your diet, but also from supplementing. So you kind of combine what you're getting in your diet if you read some labels for a couple days. And then you can add up if you need to with a little bit of supplements like some calcium. Some Tums is actually a good source of calcium for some people. Citracal is another one. And vitamin D you can get in a lot of different forms. Weight-bearing exercise is super important. So it doesn't have to be lifting weights, but that can certainly be an excellent thing, lifting weights, but also putting weight on your bones, like walking or yoga can be really good. So putting your own weight on your bones. So things like, I always say, cycling and swimming are great for cardiovascular exercise, but you're not putting that weight on your bones when you do those two things. So usually it's more of the things like walking, yoga, strength training that are really good for bone building. So that's my little spiel on sexuality, intimacy, and bone health. Our SIMS program is available to you. You can feel free to call us directly, ask your team for a referral, reach out to me. And the American Cancer Society also has a great section of their website specifically targeted to giving you information about sexuality. So thank you for your time, and I will turn it over. I will stop sharing and turn it over to Dr. Cartagena.
Thank you, Johanna. That was really fantastic. I'm also really grateful for everyone to give us our time today and for logging in and to be a part of this really amazing panel of wonderful people. I'm going to go ahead and share my screen and get started. Johanna, something they mentioned before that really struck me was we need each other, like the human need for connection. I find that it's incredibly important now more than ever, but in particular when it comes to survivorship. Let's see if I can start the slideshow. Start. Okie dokie. So I'd like to continue the conversation that Johanna just had, but take it from a men's sexual health perspective as well. And I really love having conversations that are tough to have, perhaps a little taboo, take us out of our comfort zones, but they're really worth having. So to begin this conversation, much like my colleague just alluded to, we don't really often discuss this, the idea of sexuality, sexual health, intimacy, but these are really important parts, as Johanna said, of our support system and just integral parts of what makes us human. Because what we're talking about at the core of it is connection, the ability to connect to other people and connect to ourselves. And we find that healthy sexual functioning in most of the studies that we do really does predict better emotional, psychological, and physical long-term outcomes, particularly among folks who have cancer. And so sex and intimacy can have also, as many of us know and feel in our daily lives, these personal, social, cultural significances and importances. And the idea of sexuality and intimacy and even that vulnerability that's kind of inherent to it has really distinct implications for men. And they're far less discussed overall. There's these ideas, and they may vary through personal experiences, social and cultural experiences of being the provider and what that means, the roles that one might have in their existing relationships, what it means to perform in a sexual capacity or an intimate capacity. All those things bear significant weight for men. So in health, if we're not having these conversations and if we're overlooking this, that means that in treatment, they're overlooked. And so we often find that when we're discussing medical treatment or plans, for instance, sexual health might be organized a lot lower in priority inherently by a medical team, and assumed that that is the prioritization that you're coming in with into the clinic. Another piece that we might find is that it's seen as something that could be compromised. Of all the things that might be less important to someone, maybe you can take this one on the chin. Maybe it's not going to be as important to you. When for some people, it's not something that's easily compromised. It's an inherent or an important part of their ability to connect and live their lives happily. There's also a sort of conversation that many folks have with regard to perhaps an expiration date being placed on what sexuality and sexual health might mean. That might mean that men are saying, I'm too old, to this, too in pain, too ill in order to do these things. And that's the predominant conversation that then kind of looms over treatment and then your outcomes. But a key thing to hone in on is that sexual health is health. It is a part of one's quality of life. Each of us has a completely different ratio with regard to how important it is or the role that it plays within our lives, but to overlook it means that we're overlooking key parts of the whole story when it comes to our health. So that being said, cancer can take so many things from us to begin with, and the physical implications of cancer can take a really heavy emotional toll, and particularly for men, stigma and shame around sexual health, including things like performance and arousal, make it really difficult for men to talk openly about their concerns, and then therefore get access to the care and support that they might need to make their holistic health even better. And once this happens, we really run the risk of worsening our mental health and our physical health outcomes, our quality of life, and even our potential for recovery. So cancer treatment in and of itself can take a significant toll on sexual health for men. And it's really important to just briefly discuss the ways that we could expect this to happen. So for instance, with radiation therapy, men might find or expect that the radiation level or location might increase risk of impact on fertility. And that might be something that they want to have a conversation about with their provider beforehand, before making a choice about their treatment. Might impact blood vessels or nerves or increase risk of erectile dysfunction. Chemotherapy has been found in several studies to perhaps impact testosterone levels and lower libido, similarly with hormone therapy too. Surgical interventions might impact nerves, sometimes impact semen production or the sensation of something like an orgasm. And then medications, as Joanna also alluded to, may also have side effects that include impacts on erection, impacts on libido. And each of these pieces is really key and critical when we're making decisions about our care and how to survive and how to live our lives. We start to think about the different options and weigh what the implications might be for any one domain of our lives. Because once we start the treatment, start moving forward, we, in terms of survivorship, move forward with these implications and live with these side effects too. So to have the conversation at the front end is an incredibly important thing. But there's also the after effects that we often talk about. The fallout of cancer treatment and its implications on survivorship can really have lingering psychosocial impacts on sexual health, as in addition to the medical pieces. And it's really interesting because we often find that the intersection between mental health and sexual health holds more stigma even still. And men can find that after cancer treatment, they might have lingering, let's say, pain or fatigue. And physical pain can complicate sexual activity if that's something that you want to jump back into. Fatigue secondary to treatment, much like Joanna had mentioned, can severely reduce libido. It's hard to engage in activity that you really like to do, even if it is sex or intimacy, or if it's in another domain too, if you're feeling fatigued, if you're feeling low energy. And medication management, as I mentioned on the slide before, has side effects that can compound the effects that you're already feeling. From a mood and anxiety perspective, unsupported sexual health can often find a deep increase in depressed mood and anxiety. If you're noticing these changes, a shift from your baseline, a complete new normal, as we often say in the clinic, it can be really disconcerting and really demotivating. And we find that it starts to incite a cycle. That worsened mood and anxiety can then, in a roundabout way, complicate performance even more. Worsened mood and anxiety can impact interpersonal relationships because it becomes really hard to explain this to someone that you care about, a partner, for instance, or another individual that you're interacting with, when you are kind of the singular person having these experiences. So that being said, how do we support and improve sexual health? So we can take two approaches. The first one is from the psychosocial angle. So I'll start there. The first thing I ever tell anyone is to really identify your values regarding sexual health. As I mentioned before, everyone has a different perspective on it, ratio with regard to its level of importance and the role that it plays in your life, either from a personal, social, or cultural perspective. Identifying what your values are throughout survivorship, throughout your treatment, is crucial to starting a good foundation with regard to where do I go next to supporting this part of myself. Communication is also incredibly key. It's a difficult piece, and we often find that through psychotherapy and through the support systems that we offer, much like also Kristen alluded to, that we can help and support and enhance communication. And communicating what your desires, your perspectives, and your limits might be to your partner can set a good foundation for where you go and what you start to try next when it comes to supporting your sexual health. I also really stress that one should afford themselves the opportunity to get to know yourself. Cancer takes so much from us. It changes so much of our body, of our mind, of the way that we live our lives and the way that we see our world. So it is well within your right to start to get to know yourself, to know what your body is capable of, to know the new you, and to love and cherish that new you as well. And then also to kind of piggyback on something that Johanna had mentioned that I really appreciated was to recognize that sexual functioning and intimacy are not one size fits all. They can look like many different things from a social perspective and perhaps cultural perspective too. We might have expectations of what they might look like, but for each one of us sitting here today, it looks a lot different. And that's okay that it looks a lot different too. Patience is incredibly important in this process as you begin to know yourself, try out new things, have new discussions that might have been difficult or uncomfortable to have before. And then further, connecting with professional support can really give you the skills and the practice that might be needed to go through this uncharted territory. So something that I practice, one of the many evidence-based treatments that I practice in my clinic, cognitive behavioral therapy, can really help folks develop skills to support the adjustment that really comes with the physical changes and the psychosocial changes, and also help manage the way that you think about and engage with sexual functioning. And even things like sensate focus therapy, which is more sex therapy specific, but that can also help you identify ways to engage in intimacy and stimulation at a pace that's comfortable for you, at a pace that makes sense for you. And then from the medical perspective, we can also follow some of the same routines and then start to have these really critical conversations with our medical team. So for instance, identifying your values for sexual functioning and communicating them to your medical team is really crucial, particularly at the front end, but there's no wrong time to ever have this conversation. Discussing the pros and cons of treatment plans with your values as the context, the framework for what you want to do, the framework for how you want to live your life is a really important conversation to have with your medical team too. And discussing the pros and cons of any interventions down the line to support healthy sexual functioning are going to be fantastic as well. So for instance, different medications exist like Viagra or Cialis, and there's also different physical interventions that men might be able to discuss with their providers too, including penile injections or vacuum constriction devices. Using this knowledge then helps you align your treatment and your choices with what's important to you. No matter what perspective we take, I think one of the most important parts of treatment is that your quality of life and your desires for a life worth living are very important and central to what you do next and central to survivorship. And for many people, sexual health can be a really important part of that. And though the lifetime burden of cancer can be extremely heavy, that does not mean it must take away everything that brings you value or that brings you joy. And treatment and care do not need to sacrifice healthy sexual functioning for men in order to get you to a place where you're surviving. We want you to more than survive. We want you to thrive. So that being said, here are a few different resources I often recommend to folks across different organizations and platforms just to help continue this conversation and keep it going. The American Cancer Society has some great infographics as well as bodies of information about cancer in the male body and sex with regard to adult males and cancer, and organized by cancer type as well, which is really helpful. Cancer.gov folds in a lot of really great conversations about self-image and sexuality for men and other predominant sexual health issues. And the NCI has really great information and skills and tricks with regard to communicating with your partner in this arena. And there's a really great podcast too, specific to prostate cancer, but there's some really great material out there to support everyone. Thank you so much for your time. I'm looking forward to answering any questions if anyone has any. I'll stop the share and I'll hand the baton over to the great and powerful Scott.
That was great. It's hard to follow the three of you because the three of you did an amazing job. And Johanna, you did an amazing job of setting the stage for me too. Even though I'm not specifically talking about bone health today, you hit on all the topics, and you're right that I will say that for me, as a physical therapist, sometimes it's hard for me to have these conversations like with Gabe and Johanna, what you're talking about here. But I can use the menopausal changes. I can use the loss of bone density to say, this is why we're doing these weight-bearing exercises, because I know that this hormone therapy can lead to bone loss. And I also know that this medication can lead to sexual changes. So if you are experiencing any concerns like that, then I have some resources for you. So it gives me an in, it gives me an easy in. So again, this is just how we all kind of work together, which is great. But I'm not talking about bone health because Johanna did an amazing job of that already. I'm going to talk about neuropathy. And I will say neuropathy can affect both the hands and the feet. As a physical therapist, I'm going to address really neuropathy that we see in the feet and what that can do to a patient's quality of life. So as we move forward here, I've heard neuropathy described a variety of different ways, and if you have neuropathy, I'm sure you have your own unique way of trying to describe it to family members and friends of what it feels like. I'll never forget, I had a patient years ago who told me that her feet felt like two dead fish. And I've heard the gamut of numbness, tingling, buzzing. Like I feel like I've got like my socks are rolled up underneath my toes. I've heard it all. But ultimately, what this is coming down to is that certain chemotherapy drugs, not all chemotherapy drugs, but certain chemotherapy drugs cause nerve damage, and specifically peripheral nerve damage, which means the nerves that go to our fingertips and go to our toes and our feet, almost in like what we would consider a stocking glove distribution. And what this can lead to, in my mind, one of the biggest things that I am concerned about if somebody is referred to me and they say that they've got neuropathy in their feet is, are you a falls risk? If you can't feel your feet, do you know where the stairs are? Do you know where that throw rug is? That sort of thing. So as we advance here to the next slide, yeah, these are all the things that I could be worried about. Again, falls are probably the biggest thing, and if you're scared of falling, then that contributes to just fear in general, which means you're not going out as much, which means you're not exercising as much, and so again, it becomes this vicious cycle. Sorry, Kristen, now you can go ahead. So. And Joanna, you alluded to this a little bit when you were talking about trying to exercise during chemotherapy, and so you're right, it's tough. And so being able to work with an oncology physical therapist or an oncology occupational therapist, someone who understands the undulations of neuropathy, these peaks and valleys, and so we can design a program that works around these peaks and valleys. So, if you're getting chemotherapy and you typically feel like you hit the wall, you kind of have that bottoming out point, like 48 hours, 72 hours after chemotherapy. Okay. Then those days, and then those days as you're recovering, maybe those are stretching days. Work on flexibility, maybe work on diaphragmatic breathing. But then as you start to come out of that, and your accounts start to come back, you start to get some energy back, then we can start to think about, okay, let's get back to walking. Let's get back to doing some resistance exercises. And for my patients who, if you're on a 3-week cycle for chemotherapy versus like every week or every 2 weeks, that's a big window of opportunity where we can really start working on ramping up that exercise. And that's one of the things that we find with neuropathy specifically is that we need to be doing weight-bearing exercises. We're trying to get input into those feet as well as cardiovascular exercise. So as we move forward, so I always like to refer to the American College of Sports Medicine exercise guidelines, which came out in 2019. Interestingly enough, I will also use these, in hand in working with Kristen, especially when patients are describing anxiety and depression, which can lead to fear of recurrence. And so, so Kristen's got her interventions to be able to address fear of recurrence. And now we've got the evidence that shows that exercise, specifically cardiovascular exercise, can help with that as well. But again, when speaking about neuropathy specifically, again, we're trying to target cardiovascular exercise first and foremost. Even though it is an injury to the nerves, we still want to be able to increase blood flow to the muscles to try to help with the healing process there. I also will tell my patients too, to try to be as transparent as possible up front. Nobody's got a perfect cure for neuropathy. Even the medical oncologists, they now are prescribing duloxetine, which is Cymbalta. The oncologists used to prescribe gabapentin. But even that's not 100% effective. So I do try to, be very forthcoming with my patients to say, listen, I may not be able to take the neuropathy away, but if I can make you stronger, if we can get you so that your balance reactions are better, so that you are less likely to have a fall, then I would call that a win. Right. So as we move forward. So yeah, so these are some of the things. If you were to come to me in physical therapy and you're telling me you've got neuropathy, we're going to be doing obstacle courses. You need to know where those feet are in space. We are going to be doing different balance activities. We're going to start with more what I would call static, where your feet are on the ground. But I might make the ground uneven, having you stand on those foam cushions. And then from there, I'm going to make it more challenging. I'm going to try to make it what I call more dynamic balance activities, where you are going to start walking around and moving around. And so that's my challenge, is to figure out how to challenge you appropriately and safely to be able to work on those balance reactions, to work on that strength, and I think ultimately, again, to work on that confidence so that you can move a little bit more freely. And as we move ahead, again, I try to think outside the box. And so again, there is no perfect one cure for peripheral neuropathy. So it may need to be a multimodal approach. I've had patients who have gone and done acupuncture, and some have said that it has been beneficial. Some have said it's not. I know that that can be a barrier to many patients because acupuncture is not usually covered by insurance. So, if you have the means to be able to do that, I think it's worth giving it a try. Therapeutic massage, which we have through the Smilow integrated medicine program, and specifically deep tissue work to the feet, to the bottom of your feet, starting at your heel, working your way up the foot, trying to get each toe. Again, you're doing two things there. You're increasing blood flow to the area, and also that tactile input. The bottom of your feet actually feeling your fingertips is good to try to get those nerves to try to come back online. Which leads me to talk about sensory strategies. I steal these ideas from the OTs a lot, but to try to introduce, again, different textures to the bottom of the feet. And I would say also, if you have neuropathy in your fingers, the same thing. Look around your house for a couple different textures. A shower loofah, a piece of felt, a knit scarf, something like that. Nothing sharp or abrasive, obviously, but to be able to massage your foot with these different textures, you're trying to get those nerve endings to wake back up. And again, if you've got neuropathy in your fingertips, you find that you can't do zippers or buttons anymore, or you're dropping your coffee mug, I can definitely get you started on some hand exercises. But if it's really impacting, fine motor abilities, like your abilities to type or to be able to hold a pen, then we can talk about getting you referred to an occupational therapist, because they are more the specialists when it comes to hands. And I think that's my last slide. It is my last slide. Great. Thank you, Kristen. So before we dive into questions quickly, I just want to make sure that we all have the phone number for the Smilow Survivorship Clinic, which runs every Wednesday. The number is 203-200-4584. And with that, it looks like we have a little bit of time for questions.
Yeah, I will start reading some of the questions, Scott. If you can just tell us the phone number one more time, I'm going to type it into the chat box.
Sure. 203.
Yep.
200 4584.
4584. So you have it here, and hopefully everybody can see that, and we'll do a quick Q&A and keeping time and interest. So the first question, I'm gonna just point right to Kristen. What's the best way to describe post-traumatic growth to a friend or family member? How can I define it for somebody in my circle?
Okay, that's a good question. I know the the textbook definition can be difficult, most definitely for family or friends to understand because, they may not have gone through this particular experience, thankfully. But the way I usually tell people to describe it to friends or family is essentially a positive transformation or a positive change that I or a person has undergone after experiencing a traumatic event. You could also describe it as a new, I may have a new awareness or a new insight, a new perspective that resulted from my cancer diagnosis. Really emphasizing to those individuals too what that may look like for you. So I did peek at your message, and you had mentioned that you have experienced post traumatic growth. To the individual that asked the question. But, if you know how that area of growth has already occurred, really highlighting, as a result of my diagnosis, I have experienced, XYZ. I have experienced a newfound appreciation for life. I have experienced spiritual growth. I found God. I changed my religion. I discovered new things about myself that I didn't know before. Really giving those specific examples could be helpful for our family and friends to gauge or have a better understanding. Hopefully that answers your question.
Thank you, Kristen. I'm going to go back and forth between the Q&A section and the chat box. So just bear with me as I read these off. Could you explain how hormones are used to make sexual health better? So depends on the cancer. And I think Dr. Cartagena also will say from a male perspective, it depends on the type of cancer and whether you can have hormone treatment, like different topical creams, pills, patches. There's lots of different hormone therapies that can help with menopausal symptoms, but also sexuality concerns. So those will be questions for your individual provider. Come to the SIMS program, talk to your gynecologist. But there are hormone therapies for certain patients, depending on the cancer type, that can help with sexual health. The next question, what does porous bone health feel like? Again, you don't feel it. So it's no symptoms. It's not the achiness. So losing bone density, we don't know until we unfortunately break a bone, which is why it's important to try to catch it with a bone density exam. Scott, this one's for you. I have neuropathy and my body is dependent on gabapentin. How do I wean off of gabapentin?
Yeah, that's a good question, and it's tough. I think to continue to have that conversation with your provider, to say that, what can we do to responsibly start to maybe titrate that down a little bit. So that is definitely a conversation to start with your provider. In addition to that, I would say, again, whatever exercises that you can tolerate. And again, some people, because I went through the chat quick, somebody else made a comment about their neuropathy being burning pain. So maybe walking is not going to be the best mode of exercise right now. So maybe we need to think about like a bike, or maybe we need to think about the pool. So often I will tell patients that if you can get in the water, so whether it's the YMCA or, now it's the summer, if you can get in a pond or a lake or the sound, the water is going to do a couple things for you. The hydrostatic pressure of the water is going to give your feet that input that it needs. At the same time, that the buoyancy of the water is going to support you and unweight you, and so it's going to make it easier to walk. So if you can get in a lake over the summer, or you can get in the pool, that might be another means, another possibility for exercise, to try to help decrease those neuropathy symptoms. But again, as far as talking about medication dosage, you definitely want to start with your provider first with that.
Yeah, and we can work with you on kind of working with adjusting different medications as well. And Scott, you got a nice shout out from Deborah. Deborah said, I want to thank Scott and his staff for helping with neuropathy. And I don't always have to use my cane anymore, so I can carry groceries and work in the garden again. So Deborah's telling everybody, be patient, and PT works, just give it time. So thank you for that, Deborah. We'll do one or two more before our time is up here. So, how long post-treatment can people benefit from neuropathy physical therapy, Scott? Is there a
That's
time when
another
it's
good
too late?
question. There's definitely, if we can get to working with you within the first 2 years, we tend to find that if after 2 years, there isn't a lot of significant change, that doesn't mean there can't be any change. And again, it doesn't mean that we can't work on other things such as, quad stability, hip stability, core stability to make you a little bit more stable on your feet so that you're less of a falls risk. But definitely, I would say honestly, if you can get to PT in the middle of treatment, we can start things early on. Keep those muscles engaged, keep those nerves engaged as you go through treatment, and then definitely post treatment. You can definitely come in and I would say again for neuropathy, if we can get you within the first 2 years post treatment, great. But even if it's 3, 5 years later, there's still things that we can work on.
That's great. Thank you, Scott. So, and then I'll just do the last one real quickly because then I think it's time for us to wrap up, and I'll defer to Emily on our wrap up time. But as far as bone density, feel free to ask your provider whether you would need a bone density. Depends on certain factors like your risk factors, premature menopause, and different other risk factors like chronic steroid use, things like that can depend on when to get a bone density test. So ask your team about that. And yes, osteoporosis, bone loss can be reversed with not only doing the exercises and calcium and vitamin D, but also with medications if needed for osteoporosis. So hopefully that answers some of your questions. And I think we might be short on time. So Scott, I'll let you wrap up with any other things you wanted to mention. Otherwise, thank you all for joining us.
No, I was just going to wrap up and say this was another amazing Smilow shares to celebrate Cancer Survivorship Month. I know really it's Cancer Survivorship Day, but we have Smilow, we have turned it into a whole month of recognizing all the amazing things that our providers do for our survivors and recognizing our incredible survivors, their co-survivors, their family members that take care of them. And that could be immediate family members, friends, could be social media contacts, could be whoever it is, right? So um, and so we're very grateful that we are able to continue to do this. It seems like these are very successful. So, but we do want to hear from you as far as what are future topics that you want to hear from about. So, please let us know. And again, when it comes to these referrals, then if you want a referral to Kristen, or you want a referral to the Sims Clinic, or you want a referral to see Gabe or to me, please, we're asking you to ask your providers, to be able to get those referrals to get to us, because we want to help you live a better quality of life during treatment and after treatment. I don't think I have anything after that.
Well, thank you all for joining us, and we hope that you enjoyed this. We hope you got something out of it. And again, I'll echo Scott. Feel free to reach out to any of us. We may not get back to you right away, but we'll try our best. And of course, talk to your teams if you need referrals to any of our services. I can't say better things about Kristen and Dr. Cartagena, who is new to Smilow, but has actually spent a year with us on the Sims team and has really done amazing work with our patients in sexual health. So you guys have been great. We're happy to help with anything that our patients need, and we're always here for you.
All right. Thanks, everybody. And everybody be well and enjoy the summer. And we'll see you again next June for our next series of Smilow shares.
Thank you.